Morning, Shalmi ma'am. So today, one of the commonest condition that we see as pediatric orthopedics in our clinic is vitamin D resistant rickets, and we have Dr. Shalmi telling us what is not vitamin D resistant rickets. A very interesting topic. Dr. Shalmi does not need any introduction. She's a pioneer endocrinologist in the state of Gujarat for pediatric patients. She has been practicing since 2009 in Ahmedabad at EndoKids Clinic. She's convener of growth chart training and has authored multiple textbooks in pediatric endocrinology. She has taught pediatric endocrinology to pediatricians as well as orthopedic surgeons and pediatric orthopedic surgeons as well since many years. And she has a wealth of pediatric diabetes patients, uh, pediatric endocrinology, growth patients, and lots of patients we learn from when we learned with Dr. Mollin at OrthoKids. So over to you, madam. To
Yeah, thank you very much. So, we are not going to talk about what is not vitamin D resistant rickets. Rather, we're going to talk about what is vitamin D resistant rickets. Okay.
perfect.
Yes. Okay. So, I think in the last class with Dr. Ruchi, we learned, what is nutritional deficiency of vitamin D, how does it present, what are the common symptoms, and how do you treat them, right? Now, sometimes, like the rickets that you see is not always going to be because of vitamin D deficiency rickets. And that is what we are going to try and learn how to find out when it is not a pure nutritional rickets. What are the red flags? What all investigations do we do for that? And what treatment do we offer? Right? So before we go on to that, I mean, I'm sure Dr. Ruchi must have discussed this, but I'm still going to touch base on this because if you know this basic flow chart, it is very, very easy for us to identify a vitamin D pure resistance rickets, right? So we know that vitamin D, once it goes into the skin, gets formed in the liver by the help of 25 hydroxylase enzyme, it gets converted to 25 hydroxy vitamin D, right? This goes in the kidney, and in the presence of the enzyme 1 alpha hydroxylase, you have what is known as your 125 dihydroxy vitamin D, that is calcitriol. So remember, calcitriol is the active vitamin D, and this is going to act on your vitamin D receptors and cause calcium absorption from the gut. Right. So I think this basic knowledge is very, very important. Right. So if something goes wrong here, right, at the level of 1 alpha hydroxylase, that your 25 is not going to get converted into 125, that is your vitamin D dependent rickets 1. And if something is wrong at the level of vitamin D receptors, so you have the active form of vitamin D, but it is not able to act on the receptors. So that is actually the true resistance that we talk about. That is called your vitamin D dependent rickets type 2 or a pure vitamin D resistant rickets, right? So if we just know this basic physiology, I think we know what type of investigations to do. We know how to interpret these investigations, because somebody would order a 125 dihydroxy vitamin D, but if you're not able to interpret it, then that is of no use, right? So I hope everybody is clear with the basics of vitamin D physiology. 25 hydroxylase in the liver to make 25 hydroxy vitamin D, 1 alpha hydroxylase in the kidneys to make the active form, that is your calcitriol, right? Which sometimes you give as medications. And this is supposed to act on your vitamin D receptors. The main role for vitamin D here is absorption of calcium from the gut. So then what is non-nutritional rickets, right? Because we know that most of the cases that we encounter are because of a deficiency of vitamin D and calcium and phosphorus. So what is non-nutritional rickets? You have got signs and symptoms of rickets. X-rays are suggestive of rickets, but this is not because of a nutritional deficiency of either calcium or vitamin D or phosphorus, right? And therefore, when you give these treatments, the rickets does not usually get better, right? So here we are going to keep non-nutritional rickets. I'll be discussing hypophosphatemic rickets a bit separately, right? So it will not usually respond to these kind of treatments. Now, remember, whenever you deal with non-nutritional rickets, make sure that you have given adequate doses of vitamin D and calcium to a rickets before labeling that child as a non-nutritional rickets. The most common mistake that we do is when we jump to diagnosing your resistant rickets or your non-nutritional rickets is we do not give adequate doses of calcium and vitamin D. Either we just give vitamin D 60K or we just give vitamin D and we do not give calcium. So remember that would be an inadequately treated nutritional rickets, right? So before you label somebody as non-nutritional rickets, make sure that if you have had rickets, say you haven't had the chance to get the investigations done, make sure you have given adequate dose of calcium and vitamin D before you go on to diagnosing your non-nutritional rickets, right? So I think this point is very, very important. Most of us tend to subnormally treat rickets. They need large amounts of calcium in the first 6 to 8 weeks. We have learned that in the last class, right? So make sure that is done. And then you go to diagnosing your refractory or resistant rickets. Or sometimes there could be conditions that present to you as rickets but are not rickets, right? So those are the typical rickets mimics. And we are going to just go through a couple of cases to learn about that. If there is any doubt at any point, just put up in the chat box or something so we can discuss it straight away. Yeah. Right. So you have a kid of nutritional rickets, you have a suspected nutritional rickets, you have given proper doses of calcium and vitamin D, but still the radiographs are not showing signs of healing. So we learned last time, right? By 6 weeks, the X-rays start to show some signs of healings. A severe rickets may not heal completely by 6 weeks, not even by 3 months, right? But they will start showing some evidence of healing, or the biochemical parameters should start improving. But if that is not the case, right, then you are suspecting first a poor compliance. So again, making sure medicines have been taken properly. Second is malabsorption, right? This child could have a gluten insensitivity. Whatever medicines you are giving is not being absorbed. So rule that out and then move on to your non-nutritional. So either your resistant, your refractory rickets, and investigate accordingly. So when do we suspect, right? Say from the first go, when do we suspect that this could not be like a pure nutritional rickets and maybe something else that we might be dealing with, right? So you have got a family history positive, like we had this twins. So both the kids affecting with the same condition, less likely to be a nutritional rickets, right? Or there could be features of a specific condition, like sometimes we do encounter our kids of McCune-Albright syndrome, right? So there could be like precocious puberty. This girl is just 3 years old. The breast enlargement has started. Or if you can see, there are cafe au lait spots right on the back of this child. So if there are features indicative of a specific condition, right? So when I say gluten insensitivity, it causes malabsorption. So it affects the absorptive capacity of the gut. So whatever medicines you're giving, maybe only 20-30% are getting absorbed, right? So that is what we, or say somebody has got an irritable bowel syndrome, too much of diarrhea, those medicines will not be absorbed. So that is how gluten insensitivity can affect treatment. But if you put the child on a gluten-free diet, then things get better. So I hope that is clear, Kunal, right? So either you have got a family history positive or there are features which can point to some other diagnosis, right? Or associated with alopecia, right? Because vitamin D receptors are present in the hair follicles also. So somebody kid comes to us with rickets and alopecia. Suspect this could not be a pure nutritional rickets, right? There is presence of failure to thrive or polyuria or low potassium or nephrocalcinosis. We learned in the last class, right, that rickets is a condition of the rapidly growing children. And if you look at most of these children, they are very healthy, right? So they look chubby, they look healthy. But if there is presence of failure to thrive, the child is not gaining weight, the child is very irritable, there is a history of too much of urination, too much of thirst, right? maybe you're looking at the other causes of rickets. So here your alarm should go off, right? So let us just take a case. There is, I think, some question in the comment section. How precocious? So precocious puberty and cafe au lait pause do not directly contribute to rickets, but they are a part of a syndrome called McCune-Albright syndrome. And those kids can present to us with hypophosphatemic rickets, right? So if you have these features along with rickets, you definitely look at rickets, but probably you're looking at a non-nutritional or a different kind of rickets, right? So any of these markers, please see that your proper investigations are done, right? So we have got here a 3 years and 8 months old child. She has come to us with multiple bony deformities. There are history of fractures in the long bones 2 times in the past. The child is very irritable, has delayed gross motor milestones, delayed dentition, and there are frequent history of lower respiratory tract infections. Now, remember, whenever we are dealing with pediatrics, it is very, very important to get a proper past history, to get a proper birth history, because you will be dealing with a lot of kids of cerebral palsy also, right? Who can come to you with osteoporosis. So, getting a proper birth history, a proper past history.
हे थोड़ा endocrinologist
Hello.
She, can you please mute?
Yeah. Okay. Remember, very, very important to take a developmental history, right? So you know if these affections that have happened in the past has caused any delayed development in the child or not. Then you know how long the disease onset has been, how severe the disease onset has been, right? So whenever we are dealing with pediatrics, I think it's not just looking at the X-rays and treating them, but getting a proper history, which is also very, very important. Right. So this child definitely had delayed gross motor milestones, had difficulty in walking also. And because all these were happening, the child had received multiple doses of vitamin D earlier. We as pediatric endocrinologists, and we urge you as pediatric orthopedic surgeons to start using growth charts, right? Because that will tell us what the limb length looks like. And once you start treating, how well the child is responding in terms of growth also. So this is a growth chart that we use for kids less than 5 years.
Other participants are recording audio to use the summary feature.
Okay, good. So here you can see that the height which is in the upper portion is quite below, right? So this child is quite short. So maybe there is something going on with the bones that is not allowing the bones to grow longer, right? And this is what the child looks like. You can see there are signs of florid rickets, there are widened wrists. The child is very irritable. There is so much of genu valgum going on there, right? So it's like a spot diagnosis that yeah, this is rickets, right? And this is what the X-ray also looks like. Very severely ricketic bones. All the typical features that we see on the rickets, what we have read, all this is present in this child, right? So we went on and went with the investigations. Now remember, irritable child, delayed milestones, received multiple doses of vitamin D. So now I don't want to treat this as a nutritional rickets. So I want to make sure I'm ruling out the other causes of rickets also, right? So we get a hemogram, malabsorption can cause anemia, right? So you look at your hemoglobin, you look at your liver function test, kidney function test. Very important to look at your electrolytes, right? Because sometimes the kidney issues can come with acidosis, metabolic acidosis. And in those kids, your bicarbonate levels are very, very low, right? A kidney failure will have issues with your potassium levels, right? So before you move ahead, all this basic systemic screening has to be done. We did a calcium which was very low, only 7.4. Phosphorus is also very low, 3.2. Alkaline phosphatase is very high, so rapid bone turnover is happening. Then we went ahead and did the other parameters. So we did a urine calcium creat ratio. Is the child losing calcium in the urine? No, that is not the case. That is normal. Then we went ahead and did the vitamin D. So your 25 hydroxy vitamin D, which is very high. You can see, right? Because the child has received multiple doses. So the vitamin D level is very high. But if you look at your 125 dihydroxy vitamin D, that is very low, right? So the child has got vitamin D, it is getting absorbed, so your vitamin D level is more than 100. But probably that is not getting converted to the active form of vitamin D, that is your calcitriol, which is needed for the calcium absorption, right? So we learned in the slide earlier, right, that if your vitamin D is not getting converted into the active form of vitamin D, what we're dealing with is your VDDR type 1, right? So here the child is not making active vitamin D and therefore the calcium absorption is impaired, right? So what do? You're not making the active vitamin D, you give the active vitamin D from outside. So in these kids, there is no point in giving your plain vitamin D. You directly have to give calcitriol to these kids along with lots of calcium, right? Monitor your calcium, PTH, urine calcium creat ratios, monitor your growth, deformities, and as and when required, orthopedic interventions are also to be done, right? So I hope this is very clear, when to order your investigations, how to interpret your investigations, so you can manage now. So VDR1 is relatively easy to manage because these child respond very well to calcium and calcitriol, right? So let us see what happened to this child, right? So at presentation, we know that the calcium was very low. So we started with as high a dose as 100 milligram per kg per day of calcium. So I always tell Moulin's fellows, right, that now we start learning calculating the doses in milligram per kg per day because we all deal with pediatric patients. So it cannot be 1 BD anymore. We need to know exactly how much dose we are giving. We put this child on calcitriol, right? This is what the height and weight parameters look like. So at 6 months, you can see that now the calcium level has normalized, the alkaline phosphatase has come down, the PTH levels have normalized. So now we have gradually started decreasing our doses of calcium. Remember, still at 6 months, the growth has not picked up. The height, which was 77 centimeters, is still 77 centimeters because the bones are getting stronger. Now they will start growing as well. So on further follow-up, a growth modulation surgery was planned because the child had severe genu-valgum, right? So now at 1 year, you can see that the child is picking up on the height also. So from 77 centimeters, the child is 80 centimeters. We are cutting back on our doses of calcium, you can see. Again, at 2 years, the child has significantly grown better. Now the calcium, phosphorus, alkaline phosphatase levels are pretty much in the normal range, and therefore we have come down to normal maintenance doses of calcium and calcitriol. So now the child is on 30 milligram per kg per day, which is like a recommended dietary allowance, along with calcitriol, right? So these medications will go on for life because VDDR1 is a genetic condition. The child is not going to make calcitriol. So these children will need calcium and calcitriol for the rest of their life and therefore very strict monitoring as well. So this was how the child came to us, and this was after growth modulation and treating the child with calcium and calcitriol that we were able to achieve this kind of a result, right? But this child now, I think, is 17 years of age and she's still on calcium and calcitriol. So we cannot stop these medications, right? So remember, they have to be continued for lifetime. So this was a kid of VDR1, very nicely treated with calcium and calcitriol. Let's take another case, right? We have got a 1 year, 11-month-old boy. Any doubts in the previous case? I hope everybody was able to understand how do we diagnose and how do we approach these kids. Shalin, if there are any
Yes.
doubts.
What are the likely complication of long-standing calcium and calcitriol treatment?
Yeah, so as I said, monitoring is very important, right? Because calcitriol is the active form of vitamin D, and that can sometimes cause nephrocalcinosis, right? That means small calcium deposits in the kidneys, right? So every 6 months, we do advise them to get a sonography of the kidneys and a urine calcium creat ratio, right? Because say you are sometimes overdosing on your doses of calcium and vitamin D, those calcium deposits might be excreted in the urine and they may deposit in the kidneys, right? So again, over treating is also of no use. So monitor your x-rays, monitor your calcium PTH parameters, but take care of your urine calcium creat ratios also. Make sure that calcium excretion does not happen in the urine so that nephrocalcinosis is avoided. But other than that, I think if they're able to maintain normal dose of calcium and vitamin D, they are good to go.
At what time, we can rely on the dairy intake and stop oral calcium while treating this condition?
Uh, I think we would not rely much, right? Because these are younger kids. We do not know how much of dairy will they comfortably take in a single day. So we stick to the very basic lower doses of calcium. So 30 to 50 milligram per kg per day is a recommended dietary allowance, right? Um, so I think we still continue with 30 milligram per kg per day of calcium rather than just relying on the dairy for the absorption of calcium. So I think such low doses of calcium, monitoring them with urine calcium creat ratios is going to prevent any long-term complications. Any specific molecule, so calcium carbonate is definitely preferable, right? Again, depends on what the availability are. We usually prefer to give those kind of preparations that have slightly concentrated amounts. Remember, these kids are going to go on lifetime preparations of calcium and calcitriol. So sticking to preparations which have got concentrated, because you'll get some preparations which have got 150 milligrams in 10 ml. You have some preparations which have got 250 milligram in 5 ml. Then those are the ones which are preferable. Calcitriol, we usually try and taper it to a basal minimum to keep your PTH and alkaline phosphatase levels in the normal range. So we may start earlier at higher doses, 0.25 to 1 nanogram per kg per day. But then we gradually settle to the bare minimum needed so as to prevent nephrocalcinosis. So nephrocalcinosis becomes a real risk. And therefore, there are some preparations available which have calcium and calcitriol with them. We always avoid using these preparations because calcitriol really should not be used unless and until absolutely indicated. So for treating nutritional rickets, never use calcitriol. There is a high risk of the child developing nephrocalcinosis. What is the usual cost of 125 dihydroxy vitamin D? In Ahmedabad, it costs around 1200 rupees, and we usually get the results by the end of the day, but that not be the case for everybody. So earlier it used to be around 2500, but now since more tests have been done, they have come down on the cost. But sometimes they would outsource us and we get the results at 3-4 days also. Right. But yeah, I think we should wait for the results if you're really suspecting a non-nutritional rickets. What is the regimen for repeat investigations? Kunal, we discussed that in the last class. So the regimen for repeat investigations remain the same, right? So at 6 weeks, you get your calcium, phosphorus, alkaline phosphatase, PTH done. You see that your alkaline phosphatase is coming down. So I always feel that alkaline phosphatase is a very good marker that tells us that your bone is recovering. Right? It's a bone turnover marker. So if your alkaline phosphatase is coming down, if your PTH is coming down, that means the child is improving. You get your X-rays done. These severe rickets, you may not see complete resolution of the X-rays at 6 weeks, not even 3 months. But again, signs of healing start appearing at 6 weeks. That means you're on the right track. So I hope that answers your question, Kunal. Yeah?
Yes, ma'am. Yes, ma'am.
Okay, so let us move on to the next case. I've got a 1 year, 11-month-old boy. The child has come to us with complaints of not able to walk. There are signs of severe rickets. The child again has received multiple doses of calcium vitamin D. There has been no improvement, and X-rays shows florid rickets. Right? And this is what the blood picture looks like. So now here we directly went for the full panel because there is no point in again giving a trial of calcium vitamin D and seeing signs of healings. So here the child has already received all those treatments. So we directly went for the full panel. So what did we find? We found that the calcium is low, the phosphorus is low, the alkaline phosphatase and PTH levels are very high. 25 hydroxy vitamin D is also in a good range, but what strikes to us is that your 125 dihydroxy vitamin D levels are also very high, right? So here what you can see is the conversion from 25 to 125 is happening nicely. That is why you see good amounts of 125. But then why is not the calcium level becoming normal? Right? So that is the question. So is the 125 able to act on its receptors or not? That is the question here. Right? So here, as we said, we need 125, but we need vitamin D receptors also for it to act and cause calcium absorption. So if there is something wrong with the vitamin D receptors, jitna bhi hamare paas 125 hai, it is not going to act on the receptors, right? So here, this is the case of pure vitamin D resistance. There is resistance to the action of vitamin D, and that is causing such severe calcipenic rickets, right? So now these are the kids who are very, very difficult to manage, because even if you give them lots of calcitriol, they're already having so much of calcitriol in the body. They do not respond as well. They have persistent levels of low calcium, and therefore sometimes we need to give them IV calcium also to allow the calcium levels to normalize. Right. So again, very, very important to identify. This is not a very, very common presentation, but you do encounter these kids sometimes in your practice. And it's very important for us to identify these kids because they simply do not respond to your baseline dose of calcium and calcitriol. Like I have got a kid of EDDR2. The child is on almost 3.5 grams of calcium along with 10 tablets of calcitriol every single day, and still we are giving IV calcium to the child every month, right? So identify these cases, refer them to your ped endos. But yeah, again, deformity correction becomes difficult, right? Because the calcium never normalizes. So whatever surgeries you want to plan, there is no effect to these surgeries. So this is called VDDR2, or what we call as pure resistant rickets. Right? I hope this is clear. We had VDDR1, wherein 25 to 125 did not happen. So you give 125, your child improves. We have VDDR2, where we have 25, we have got 125 also. But what happens is there is deficiency of the rickets. There's deficiency of vitamin D receptors, and therefore this 125 also does not happen. So here, even if you give these large amounts doses of calcium and vitamin D, they are not going to be absorbed, right? So even if I give 3 grams of calcium to this child, because I do not have my calcitriol acting on the receptors, that calcium absorption does not happen, right? So it is not going to cause any nephrocalcinosis because calcium absorption only has not happened, right? But yeah, these patients end up, yeah, so renal stones and nephrocalcinosis will not happen here because this calcium is not getting absorbed. When will renal stones and nephrocalcinosis happen? When you have got too much of serum calcium and that gets excreted in the kidneys and that deposits as your renal concretions. But here वो absorption ही नहीं हो रहा है. Right? And इसलिए we prefer to give sometimes IV calcium so that that absorption matter is bypassed. So very
So,
difficult to
so
manage.
calcium, Shalmi, calcium gets absorbed from the intestine, right?
Yes.
And the receptors are on the bones. You're talking, right?
So receptors, so vitamin D receptors are at a lot of places,
Uh-huh.
right? So vitamin D receptor पे vitamin D ने काम किया, and then it signals the further calcium absorption,
Okay.
right? So say, for example, I take 1000 milligrams of calcium every day, right? If I have good amount of vitamin D intake in my body and everything is in place, my systems are working fine, I'm still going to absorb only 60 to 70% of my 1000 milligrams of calcium. But if I am severely vitamin D deficient or my vitamin D is not able to act, I might absorb only 10% of the 1000 milligram that I'm taking, right? So vitamin D's main role is calcium absorption, but it needs to go through these channels for the calcium absorption to take place. So I hope this is clear.
Ma'am, I also wanted to ask if excessive vitamin D is given, will it
Yeah.
cause hypervitaminosis symptoms or something like that?
देखो, हाइपरविटामिनोसिस का जो सिम्टम्स है वो दैट इज बेसिकली बिकॉज ऑफ हाइपरकैल्सीमिया, right? So when we say vitamin D toxicity,
Yeah.
vitamin D toxicity symptoms are because of high calcium, not because of high vitamin D.
Okay.
ठीक है, उसने बहुत सारा कैल्शियम को अब्सॉर्ब कर लिया, कैल्शियम बढ़ गया, एंड दैट इज कॉजिंग द टॉक्सिसिटी,
Okay.
राइट? हियर इन दिस केस आई एम गिविंग सो मच ऑफ विटामिन डी, पर वो, सो आई एम ट्राइंग टू हियर सैचुरेट द विटामिन डी रिसेप्टर, कि अगर 10-20% भी बाकी है कुछ, let me just give too much of vitamin D and see if it works a bit.
So we don't give IV drugs in these cases.
So that we are able to avoid IV, because you know IV calcium has its own complications,
Yes, ma'am.
right? We have to admit the child for 5 to 6 days. We have to give them IV infusion continuously, और वो हर महीने करना पड़ता है, so that some calcium goes directly into the blood and directly into the bones, and therefore the bone strength increases, right?
Yes,
Because
ma'am.
it's a genetic condition. We are not able to take care of the core problem, right? So we
Yeah.
try to give lots of calcium and vitamin D here to saturate and, you know, kind of overtake the deficiency. Most often or not, we are able to just, like, you know, maintain a reasonably okay level of ambulation. But otherwise, again, if your calcium levels start dropping, you have to go to your IV calcium.
It's
Clear?
safer to overdose on vitamin D, but not on calcium, because calcium causes most of the symptoms.
Yes, but here, because look, for the calcium to absorb, we need a proper vitamin D. So even if I'm giving 3 grams of calcium to this child, it is not being absorbed because my vitamin D is not able to work,
To work.
right? Now, whenever we talk about a genetic syndrome, there is a spectrum. So there could be milder cases, there could be severe cases, and there could be cases in between. So we hope that there are cases in between which would respond to supraphysiological doses of calcium and vitamin D. Right? But if you have a severe case, you end up giving them IV calcium every month. So I hope that is clear.
Yes, thank you.
But refer to a ped-endo, please.
Yes, ma'am.
Let us do that job. Yeah. So can we move on?
Yes, ma'am.
Yes, please.
Yes. So I think, you know, for us, it is important that we are able to diagnose these kids correctly, so that we just don't blindly give them calcium and vitamin D and wait for the recovery to happen. We know when we are dealing with a kid which is not plain nutritional rickets, so we can order investigations accordingly. We are able to interpret investigations accordingly. And, you know, VDDR1 is still very, very manageable. So at least that we should all know how to do it. Right? Okay. What happened? Yeah. Let's take another kid, right? So she comes to us at the age of 13 years, with complaints of short stature, knock knees. There are no other complaints, but the child is otherwise absolutely fine. You know, they have just come with a bony deformity, right? One bony deformity at the age of 13 years, and X-rays shows sign of rickets, right? So we get our basic investigation done. So remember age, as Ruchi ma'am was saying yesterday, you know, there are certain ages where if you have a bony deformity because of rickets, again, your antenna should go up. That probably this is not just a pure nutritional deficiency. Probably we are dealing with something else, right? So in this case, we found the low calcium. We found all the typical signs of rickets, but we did a creatinine and directly the creatinine was 3.3, right? So sometimes the bony deformity may be the only presenting sign of a chronic kidney disease. So these kids will come to you. Now, if you have not done the creatinine level and you're just treating your calcium phosphorus by giving your calcium and vitamin D, you're missing out a major cause of rickets, right? So remember getting your basic investigations done, you know, getting your electrolytes, getting your renal function test done should be a priority in all these patients, right? Because sometimes this might be the only presentation. So we should not miss out on those cases, right? But yeah, here the child was referred to a pediatric nephrologist. They were put on calcium vitamin D supplements. But again, the whole CKD management has to be started, and then they were referred to a transplant panel. Yeah, right? So these kids often have delayed growth in puberty, right? As sir must have taught you and you are going to present also, right? So we sometimes often give growth hormone to them, right? Because there is prolonged bone loss, there is a deformity. So even when you treat them, the height does not improve. Right. So after you have done the surgery, we do often give them growth hormone therapy. Now, this is not an approved indication of growth hormone therapy, like not approved by the international bodies. But again, it's a part of increasing your height, and that gives a boost to correcting your deformity as well. So here the child underwent the growth modulation and then growth hormone therapy was given. Right. So we talked about the first part, inadequately treated nutritional rickets. Then the second, your true vitamin D resistant rickets. But there could be some mimics of rickets also. Right. So they will typically present to us with a bony deformity. The X-rays may look like rickets, but they may not be rickets. Right. So these are usually genetic conditions. If you get your metabolic workup, you get your calcium, vitamin D, PTH, everything turns out to be normal. But these are ricket mimics. And therefore, before you label them as rickets, very important to thoroughly investigate getting a proper family history. So many of these conditions are autosomal dominant, right? So you'll get a subtle history in the father and the grandfather and so on. So make sure you take a proper family history in these kids, right? Um, I think this is something that you see very frequently in your practice. An exaggerated physiological genuvarum. There could be kids of chondroepiphyseal dysplasia. Maybe to us, it looks like a rickets, right? Because you have the genuvarum, you have something happening in the bones, but this is your genetic condition. It will definitely not respond to calcium and vitamin D. Hypochondroplasia, right? So again, look for a family history. Ricket mimics. Blount's disease, right? So sir has operated this case. We know that this is not rickets, but it presents as such a severe genu valgum, right? There could be metaphyseal dysplasia, right? So if you look at the father, if the father has come fully dressed to you, you may not notice the deformity here. But when you kind of dig deeper, you may find that there is a family history which is positive, right? So always make a habit of taking a detailed history for all our pediatric kids, right? Most of these non-nutritional rickets or rickets mimics will have a genetic underlying condition. So genetic analysis have to be offered to these patients, right? So let us just quickly summarize this point. Nutritional rickets is still the most common form of rickets. If the child has come to you for the first time and say you do not have investigations at your hand available, you can treat the child as nutritional rickets. But again, you know what all things to expect on treatment. And if those have not happened, move on to the next part. So if the child does not respond to therapy, the other causes have to be investigated. Thorough analysis of calcium profile. So Ruchi ma'am told you, right? Your calcium profile includes calcium, phosphorus, alkaline phosphatase, PTH, vitamin D, your renal function test, liver function test, blood gas analysis, and as and when needed, your 125 dihydroxy vitamin D levels have to be done. So this is to be done when you're monitoring the child. These are the parameters that you should monitor. You should start including getting a urine calcium creat ratio also in your monitoring panel, because you don't want to overdose on your doses of calcium and vitamin D. This is to be done only when your vitamin D is normal or high and still your rickets is there. Then you suspect some problem in the VDDR1 or VDDR2. Most of these kids might need an orthopedic intervention, right? Because as the healing starts, the deformities are quite severe. So a low threshold for orthopedic intervention should be there. Normal calcium profile with clinical and X-ray pictures like rickets, make sure it's not a partially treated rickets or a rickets mimics, right? So any questions in the prior before we go to quickly learning about hypophosphatemic rickets? Any doubts, any questions?
Ma'am, you said that the orthopedic intervention should be done early. Uh, as early as the treatment is started prior to that,
No, no,
or
no. No, no, no. So always the medical management has to be done, because unless your bones are a bit stronger, whatever orthopedic intervention you do is not going to last long, right? So the medical management has to be offered first. Say if I have a case of VDDR1, normally on treatment, I will see start signs of healing and my calcium levels normalizing by 6 months. So once those parameters have been taken care of, because they come usually with severe deformities, right?
Yeah.
And these deformities might not just get better with medical management, right? So whatever growth modulation or whatever intervention you need to be done, that has to be done after your basic medical management has been taken care of. In a acute rickets नहीं करना है. Once the rickets has started resolving, उसके बाद ही करना है.
Ma'am, in vitamin D resistant rickets, do we offer like growth modulation and everything? It has to be done in the initial periods or the after the treatment has started or has
Uh,
started
so,
before?
so any kind of rickets, say you have a kid of nutritional deficiency rickets, right? The child has come with severe genu valgum.
Yes.
Okay. You know that even if the medical management happens, your calcium levels normalize, still this child will not improve in the deformity, right? So you might want to go for deformity correction, but that should not happen before your medical management has started and it is showing its effect on the bones.
Okay.
Kunal,
So
in many such cases, especially VDDR2, even
Yes.
after long standing treatment, the bones are very weak. And what we have seen that if we have done 8 plate fixation, many a times that screw hold is very poor.
Yes, sir.
Sometimes they back out.
Yes, sir.
So we try to kind of wait for long, and many a times if the deformity is too severe and it keeps on progressing, then it's better do a metaphyseal osteotomy fixed with a K-wire, because the deformity magnitude is so big
Yes,
that
sir.
growth modulation will take long time, especially in VDDR2 where the bone health is not going to improve very quickly.
Yes.
Yeah,
Should we not
Shalmi, I
wait?
think let's go to
Yeah.
the, yeah,
We
at,
can take questions
at
at
the
the end.
end. Yeah.
okay. So we'll quickly go through managing a kid of hypophosphatemic rickets. So I think for you it is important to identify what this is and what all treatment offer options we can offer to the child. Right. So again, let's take a case of a 6-year-old girl presented to us with knock knees, notice since early childhood, very gradually progressing, but otherwise the child is completely normal. She had just mild developmental delay. Right. And this is what the growth chart looks like. So this child's height is definitely below the third percentile. Weight is still okay. So this child does have short stature, right? And this is what the child looks like. So, typical signs and symptoms of rickets are there. Widening of wrist, double malleoli, the genu valgum is also there. And these are what the X-ray pictures look like. So again, if you see, rickets is there, the deformity is there since a long time. But if you appreciate, the rickets is not as bad, as we saw in the previous cases. So there are rickets, changes of rickets are there, but they are not as severe as the earlier patients. When we got the investigations done, we found that the calcium is low, phosphorus is low, alkaline phosphatase is high, PTH is high, but vitamin D level is also low. Now remember, this child has come to us for the first time. She has not taken any previous doses of calcium and vitamin D, right? So here, this child was treated as a vitamin D deficiency rickets. The child was given calcium and vitamin D because we know that vitamin D is needed for the absorption of both calcium and phosphorus, right? So in a pure vitamin D deficiency rickets, you might find both calcium and phosphorus levels which are low. Now, after treating, this is what happened on follow-up. My calcium has normalized, my phosphorus is still low, my PTH has normalized, and alkaline phosphatase is still high, right? So here the consistent findings that we get at a 3-month follow-up is low phosphorus levels, high alkaline phosphatase, otherwise all the parameters have normalized. So here it should strike to me that something is not right. If this was a kid of pure vitamin D deficiency rickets, even phosphorus levels should normalize after giving the treatment. But here the phosphorus levels are persistently on the lower side. And you can see that on the X-rays, we do not see a significant improvement, right? So rickets has not gotten better. My phosphorus levels are still low. My alkaline phosphatase levels have not improved. So probably I'm dealing with a case which is not like a nutritional rickets, right? So this was suspected to have a hypophosphatemic rickets, wherein there are issues with low phosphorus levels. Right? Now remember nutritional deficiency. So oral intake of phosphorus, which being less and that causing hypophosphatemic rickets is like a rare case because you have abundant phosphorus available. So hypophosphatemic rickets is usually because of a phosphorus loss in the kidneys. It can be either because of your proximal renal tubular acid disorders, most common again genetic disorders or sometimes drug induced, or the more common variety that we see of our hypophosphatemic rickets are FGF23 mediated genetic disorders, right? Now, again, this is very, very rare, but you will come across these kids, so you have to be aware of these conditions. What happens is there are increased FGF level 23 levels in the blood, and this causes loss of phosphorus in the urine, right? So that is why there is hypophosphatemia here. It is most likely X-linked, but again, that is not the case always. You may get a positive family history, so if you dig in deeper, you might have a family member who's on the shorter side, or there is a mild deformity which is there, but since it was not symptomatic, nothing was done for it. What do you see on the blood work? You see that your calcium is normal, your vitamin D can be low, normal, your PTH is normal, but your phosphorus is low, right? So remember here, the relationship of phosphorus and PTH is very important. PTH does not like phosphorus, right? So when the phosphorus is low, PTH will remain normal. It will not do anything. We saw earlier, when the calcium was low, PTH was high. But here the phosphorus is low, the PTH is happy. It remains normal, right? So this should be one of the diagnostic markers that is used, that if your phosphorus is low and your PTH is also low or normal, probably you're looking at a kid of hypophosphatemic rickets, right? And then you go for your X-rays and you go for calculating the phosphorus loss and genetic analysis. And we did the genetics in this kid. She turned out to have a FEX gene anomaly. So she had an X-linked dominant hypophosphatemic rickets, right? So how do you manage? You will not be able to take care of the genetic syndrome, right? So here what you can do, so you cannot shut off the phosphorus loss. You just try to replace the loss by giving your oral phosphorus, right? You monitor the growth and development. Early treatment is very, very important so that, your deformity corrections can happen. You can have a good height prediction also. PTH, as I said, is an important differentiating marker, right? So if you're dealing with your calcipenic rickets, your PTH will be high. If you're dealing with the phosphopenic rickets, your PTH will be normal. So I think this point is very, very important to remember. How do you give phosphorus? In a dose of 20 to 60 milligram per kg per day in 4 to 6 divided doses orally. So earlier we used to make the joule preparation, but now we have got phosphorus sachets which are available, which have 500 milligrams of elemental phosphorus. How do you monitor? You look for the clinical biochemical response, you look for the radiological improvement, and then you monitor your alkaline phosphatase level. So that gets better. That means your rickets is improving. Sometimes over-treating can cause diarrhea. So I think GI side effects are the most common side effects of phosphorus supplementation. But getting these sachets have really changed the management. Sometimes, you give too much of phosphorus, PTH does not like it. So there are high levels of PTH to cause that phosphorus excretion. And that is why we give calcitriol along with phosphorus supplementation in hypophosphatemic rickets. Remember, the treatment does not stop the phosphorus loss, right? So when you're treating the child, you don't have to normalize the phosphorus levels. You want कि नहीं मेरा phosphorus normal range में आ जाए, 4 milligram आ जाए, then you're over treating, and that is actually going to worsen the treatment, right? So it is okay for the phosphorus levels to remain in the lower ranges. You have to monitor how the child is doing clinically, whether X-rays are improving, whether your alkaline phosphatase levels are improving or not, right? Always in the management of hypophosphatemic rickets, you give calcitriol. Right? As I said, PTH does not like phosphorus. So the moment you give phosphorus supplementation, PTH levels rise. and all this phosphorus is going to go out in the system again, right? So you give calcitriol, that is your active vitamin D, in this so that that will suppress the PTH. So whatever oral phosphorus you give is able to act, right? So that is why we give calcitriol, or somebody would be comfortable giving alpha calcidol also. So these are the doses that typically we use for managing um, hypophosphatemic rickets. Calcitriol can be given once or twice, but phosphorus, at least minimum 4 divided doses have to be given. This is how it is available. So we have now these AdFos sachets which are available. Each sachet has 500 milligrams of elemental phosphorus, so they can be divided in multiple doses. And calcitriol is available as 0.25 micrograms tablets or capsules, right? A younger kid may not be able to ingest a capsule, so tablets are also now available, which can be used. Newer therapies are now available for hypophosphatemic rickets, which actually address the pathology. We know that increased FGF23 levels cause the phosphorus loss. So now the newer therapy, which is burosumab, which is available, it acts on decreasing the level of FGF23, right? So therefore, phosphorus loss does not happen, and that will improve and normalize your hypophosphatemic rickets. But sadly, this is not available in India. It has to be imported through some channels, and it's a very, very expensive medication. So till this treatment is available in India, we still have to rely on giving phosphorus supplementation and giving calcitriol. In spite of adequate treatment, some patients still have persistent short stature. So, growth hormone therapy as an off label use may be offered to them. Surgical correction of a deformity for any kind of rickets, once biochemical stabilization has been achieved, can be done. These kids are prone to dental abscesses, regular dental checkup has to be done. And as I said, there would be some kids who have issues with the kidneys. So, there are proximal tubular defects, so involve your pediatric nephrologist, involve your pediatric endocrinologist in the management of these cases. So to quickly summarize, still in India, because burosumab is not available, phosphorus and calcitriol supplementation has to be done. Multiple doses of phosphorus, so compliance can be an issue. So if a child is not improving, right, always ask for compliance. How many times are you taking your phosphorus sachets? Improvement in clinical symptoms and deformity, improving growth, plotting on the growth chart, seeing the child is getting better on the height, and alkaline phosphatase are the goals of treatment. You cannot aim for achieving normal phosphorus levels here, and genetic evaluation has to be offered to all the patients. So we have a better understanding of what is happening and whether the other treatments can be offered to them or not. So thank you very much. And we can we can see the questions.
So Shaktira had asked, sometimes the blood reports does not match the picture and what to do in those conditions.
So more often than not, we have these kids where, some kind of treatments have been given. They must have received some dose of calcium or maybe taken a couple of sachets of vitamin D before they come to us. So if your clinical history is pointing to a pure nutritional rickets, here what we can do is we can put the child on proper dose of calcium vitamin D for at least 6 to 8 weeks and monitor the recovery parameters after that. Now, you have given your adequate dose of calcium vitamin D. If even after 6 to 8 weeks, there are absolutely no improvement in the x-rays or in your blood parameters, your PTH is not coming down, your alkaline phosphatase is not getting better, then we go ahead to investigate for the other causes of rickets, right? Because most often, even when we receive a patient, the child has received multiple doses, right? So the best way to approach is you are suspecting proper nutritional rickets, give it a proper treatment, and then wait for 6 to 8 weeks for recovery. If it doesn't happen, move further to your other investigations. So I hope that answers your question.
Yes, there's a question on the way calcitriol works in suppressing PTH.
Yes. So as I said, PTH does not like phosphorus, in simple language. So the moment you give, so calcitriol has a negative feedback on PTH, right? We found that whenever there is a vitamin D deficiency, PTH comes into action. So what does PTH do? It will increase the conversion of 25 to 125, right? So PTH causes increased calcitriol and it works in a negative feedback. So if you give calcitriol, now PTH doesn't need to work. So PTH levels will get suppressed. I hope that answers.
Yes, and there's a question on
It's a
current
negative
cost of
feedback system. The
current
cost of
genetic therapy for
genetic therapy, as I said, it's not available in India. So we have got a couple of patients who are importing it through different channels, and it's about almost, I think, about 5 to 6 lakh rupees a month. They are injectable preparations to be taken, like, sometimes twice a week to then graduating to once a week to then graduating to lesser frequencies. But that treatment is not available. Purosumab is not available.
and is it mandatory to do metabolic profile in nutritional rickets before you start treatment, or give that 6 to 8 weeks time?
Yeah.
Uh,
So that's what I said. Say the child is coming to you for the first time, has not received any kinds of treatment. Based on the clinical history and so you'll get the x-rays done, I hope, right? Based on the x-rays, it looks to you like a pure case of nutritional rickets. It doesn't have all those red flags. The child is otherwise a well thriving, happy baby, presented to you with rickets. It would be okay to start ahead and give proper dose of calcium and vitamin D, right? But then call the child back at 6 to 8 weeks, repeat your x rays. So, if it's a pure case of nutritional deficiency rickets, your x rays should start showing improvements, should start showing signs of healing. But if they are not there, then you are looking at some other issues, right? So, it is definitely not mandatory, it is preferable to get the metabolic workup done. But if it is not available or the child is not affording for it, then you can straight away give calcium vitamin D, but then monitor for signs of improvement on the x-rays. So I hope that answers your question, Dr. Aditya. Yeah. What all parameters indicate that we proceed with the orthopedic management? So I think we would definitely aim for normalizing all our parameters, so getting your PTH and alkaline phosphatase in the normal ranges, which might take about 3 to 6 months time also. So once that is all done, we know that most likely the bone strength is now back and you can go ahead with the orthopedic management. Often we get kids at the age of 1.5 and 2 years with rickets. In those kids, we usually wait until the age of 4 years, because we know in the natural history, it might take that much time for the deformity to get corrected on its own. So if you have a younger kid, with just a kid of nutritional deficiency, the things are getting better, then you would want to wait until the age of 4 years before offering any orthopedic management. If you have an older kid, you treat the medical management, you see that your parameters are all getting better, and you can intervene orthopedically. I hope that answers the question. In VDDR, what all blood parameters indicate? Yeah, so I think that is the case with any rickets, right? So I would be monitoring my alkaline phosphatase, my PTH, calcium, phosphorus levels, right? So those are getting better or now in the normal range. That means my rickets is under control. VDR never gets cured, right? It's a genetic condition. So it has to be on ongoing medical treatment. But it means at least my rickets is getting better. My rickets is under control. So then we can go ahead with whatever orthopedic management we are planning. Should we repeat the investigations just completing the treatment schedule? If not, then how many days? So Tashwin, I think, say you have done your baseline investigations. Now you have given your calcium vitamin D preparations and you're calling the child back at 6 to 8 weeks. You can get your blood work done and your x-rays done at 6 to 8 weeks, right? Because they will start showing signs of improvement. If not, then you can suspect the other causes, right? So maybe it is worthwhile to repeat your investigations at 6 to 8 weeks on treatment because the treatment will go for a long time, right? So in between, you are getting your investigations done to see the response of the treatment, and so that your diagnosis is getting confirmed. So I hope that
And
answers Tashvin.
when should
Yeah.
we wait for just natural correction with endocrinological treatment for deformities?
So
Do any of these
uh,
deformities correct on their own?
yes, so say a case of pure nutritional deficiency, vitamin D deficiency rickets present in you in the early years. So 1 or 2 year old kid who has come to you with genuvarum, right? You are giving them calcium, vitamin D. The X-rays are showing signs of healing. The X-rays have now normalized, but the deformity may persist. But those are the kids we know that, there is a natural history. Sir must have taught you, right? The genovarum going into straight legs and then a bit of genovalgum. This whole process might be delayed in these kids. So here we might want to defer the surgery until about 4 years of age. So even after the age of 4 years, if the deformity has not corrected, then surgical intervention may be offered to them. So even after medical management, the deformity might persist, right? So then you allow the natural growth to happen for the bones to get better by the age of 4. If not, then you may go ahead.
Perfect.
Clear?
Thank
Matlab, yeah.
Yeah.
Yes.
So in my experience, what I have seen, the VDDR ones, where you treat with calcitriol, and they respond to that treatment fairly early. In about 6 months' time, they are ready for growth modulation. VDDR2, um, they take pretty long time, and on X-ray we see cystic changes on the both the sides of growth plate, and you know that your 8 plates will not hold. So VDDR2, sometimes the family say, now sir, correct the deformity, but we always feel that you are not there, and we have to wait pretty long time. And hypophosphatemic rickets, the parameters may be very haywire, but when you go and operate upon them, bones are very strong. So, I think VDDR2 is the most challenging problem, because we cannot initiate orthopedic treatment. Rest to we can treat with surgery fairly quickly in the course.
Yes. So often after, we are seeing these adolescent girls, and especially after COVID, we had like a massive amount of patients. You must have seen your proximal myopathy, difficulty in standing up. They had these typical changes of rickets, and they presented to us with so much of genovalgum. So in those patients, they respond very well to medical treatment. The muscle strength and everything also comes back, but the deformity still persists. So as soon as your metabolic parameters are in place, your X-rays have healed. X-rays have healed, matlab rickets has healed. You can offer them orthopedic intervention. So I've got a say 10-year-old girl who comes to me with rickets. I have treated, the rickets has gotten better, but the genovalgum is still there. Then immediately in 3 months' time, you can go ahead with the growth modulation, because that time I've got a very limited window of opportunity for growth to happen. So if I want to do a growth modulation, I'm doing that on the basis that I have still got a lot of growth left, right? If my epiphyses have fused, my growth modulation is not going to work. So in those kids, we might want to do an orthopedic intervention as soon as the parameters are back to normal, right? Because we don't have much time left to grow. Yeah.
One more thing about Vaibhav asked that what are the
Yes.
X-ray changes in hypophosphatemic rickets? And in hypophosphatemic rickets, where it's a long-standing disease, we see global deformity. So diaphyseal deformity with multiple cora. And in initial time, we do growth modulation to just normalize the mechanical axis. But once they turn adolescents or young adults, we tend to put an intramedullary nail by doing multi-level osteotomies. So a diaphyseal global deformity is a sign of hypophosphatemic rickets. So Shalin, I think we can conclude and we can post questions to ma'am, and we will post the answers in our fellows teaching group. I feel it was very interesting session, and every time I hear, I learn something new. So thank you, Shalmi, and Shalin, you can conclude.
So thank you, ma'am, for a great session.